Afternoon, everybody. My name is Christopher Spaldi, and we're going to be going over how we manage a cardiac patient. This is going to serve as a general overview of what we typically find in the field for managing somebody with simple chest pain to an unstable angina to diagnosing an MI in the field. We're going to go over exactly what patients are going to be predisposed to being a higher index of suspicion for being cardiac in nature, and what their ultimate definitive care looks like for these individuals. So without delaying any more, let's just dive right into it here. So again, the objective here is we're going to identify the ECG findings that are present in patients experiencing cardiac events, understand the differences between a stable versus an unstable angina, and identify the presence of STEMIs and recognize the markings of old STEMIs. And then what we're going to do is we're going to incorporate the treatments that are available to us out in the field. So what is your typical chest pain patient? You get dispatched to a mid-40s male complaining of chest pain. What's exactly going on here, right? So there's different levels to it. We're going to go over the first part here is a stable angina or angina pectoris. What this is chest pain caused by a reduction of blood flow in the heart, often caused by atherosclerosis or a narrowing of the lumen in the blood vessel. So what's going on here is because the blood vessels have hardened over time, uh, blood cannot get to its desired location, this being the heart. And what ends up happening is a lack of oxygen gets to the heart, and that's what's causing those pain-like symptoms. Oftentimes, this is going to be exacerbated through exertion, stress, or highly emotional situations. And some of the contributing factors here are these people are going to be usually unhealthy. They may have other cardiac issues like high blood pressure, coronary artery disease, cardiomyopathies, or an enlargement of the heart. They may also have high cholesterol, diabetes. They can also be on the unhealthier side of their lifestyle, um, eating unhealthy, not sleeping well, being obese, overly stressed, those types of individuals. And then what are we going to do for these individuals? Well, a lot of times, someone who's in a stable angina, these symptoms will resolve with rest. That's pretty much the big differentiating factor between a stable versus unstable angina. Um, the chest pain, which starts with a little bit of mild exertion or moderate exertion, once the patient begins to sit down and recover, catch their breath, and rest for a little while, usually about it could be a couple of minutes to 10 to 15 minutes, the symptoms will start to resolve. Sometimes these patients will be prescribed nitroglycerin to help alleviate the symptoms a little bit faster. And they may also be on different beta blockers or statins to help combat the contributing factors that influence these types of events. Us as providers, if we experience somebody that's having a chest pain or a stable angina attack, if you will, some of the things that we're going to do is we're going to help either assist them with their own nitroglycerin, or we're going to give them some of our own nitroglycerin, 0.4 milligrams sublingually, either through a tab or a spray underneath their tongue, and let it absorb through the mucous membranes. And again, that will help increase the dilation of the blood vessels, allowing more oxygen to pass through the blood vessels and reach the heart. And again, the symptoms will now start to resolve. So moving on to an unstable angina, the big difference here again from an unstable to or stable to an unstable angina is that these chest pain symptoms do not resolve with rest. So someone again, they develop the same way. So someone who's doing some yard work or heavy lifting or goes through a stressful incident and may start developing chest pain symptoms. The big difference here is that after resting for a little while, the symptoms are still persistent. They are not resolving with rest. The pain is either staying the same or increasing, and they are now developing other associated symptoms. Some of the other symptoms that we're going to be looking for here is going to be, either radiating or referred pain, again, radiating down the left arm or up the jaw, shortness of breath, nausea, vomiting, or even the patient may be a little diaphoretic as well. These people, they're going to be kind of working, they're going to be a little bit more emergent, they're going to present a little more emergent. They may have taken their nitroglycerin and they still don't have any, the symptoms still haven't resolved. It's going to play into the emotional factor to the patient and could potentially make things worse for their condition. Us as providers, again, we're going to be doing a thorough assessment on them, thorough questioning, get our OPQRST, get our sample history, and then we're going to go down our cardiac line of questioning. Do they have a history of different types of cardiac events? Have they ever had a myocardial infarction in the past, high blood pressure, stroke or any kind of clots in the past, DVTs? Those are the kind of things that we're going to be more cautious about. We want to get a good, thorough history of their medication list. Are they allergic to anything, right? So even if we have a poor historian here, if they have an up-to-date medical list, we can get a better idea of what's going on with the patient. Or if they have any other documentation like previous discharge summaries or workups from a cardiologist or a primary care provider, we want to do our thorough investigation and see if there's anything on that paperwork that can kind of go along lines of hey, this person's having a cardiac event right now. And when it comes to treatment here, these patients may also have their own nitroglycerin. We either, as an ENT, we're going to be assisting with them taking their own nitroglycerin, or we're going to be giving them some of our own. And again, that's 0.4 milligrams, given sublingually, usually either with a tab or with a nitro spray. Some places are still going to use nitro paste. That's still in the protocol, depending on where you are. Always revert back to your local protocols on how you treat this patient. We're also going to, in addition to the nitro, we're going to load up some aspirin as well, and a platelet inhibitor, just in case there is an underlying clot that we're concerned with. Help with the platelet aggregation and allow for blood to flow better to the heart. Again, before we give any kind of medication, we want to go through our 5 R's and make sure that this is the right drug for the patient, right dose, not expired, giving it the right route, all those things. We're going to go through that checklist in our head before we give a patient a medication. We also want to make sure, especially before we give them aspirin, that they have no bleeding disorders, no history of ulcers in the past, because those would be have a negative impact on the patient if they have a bleeding disorder or internal bleeding going on. And then rapid transport to the hospital, definitive care. Usually we're somewhere, there's cath lab capabilities, even if they're not having a STEMI. We want to get them to a facility that has the capability if need be. Again, with this, we're going to do our routine assessment, we're going to follow up with our chest pain assessment, and then we're going to also do an ECG 12 lead to just kind of confirm that there is or is not any kind of underlying abnormalities going on in the heart, whether it be a STEMI or a bundle branch blocks or anything else of that matter. The next thing that we're going to kind of go over here is going to be a myocardial infarctions, or what we call in the field STEMIs. And what a STEMI is prolonged lack of oxygen to the myocardial cells. MIs will cause irreversible tissue death to the myocardial. So unlike smooth skeletal muscle, once cardiac muscle dies, it does not regenerate. That's why time to definitive care is very important. By identifying someone having a STEMI, we want to facilitate transport as quickly as possible. So this is going to involve, doing our 12 lead. Once we confirm the STEMI, we want to call the alert out in the field. We want to load the patient up. We want to load the patient with a platelet inhibitor as long as they're able to accept it. And then we also want to treat with nitroglycerin, oxygen, and maybe even some morphine or fentanyl for pain management. Before we give nitroglycerin and an MI, we also want to confirm that there's no inferior wall involvement, right-sided involvement. If it's an inferior wall MI, we're going to do a right-sided 12 lead just to make sure there's no right side involvement. because that's going to be a contraindication to give nitroglycerin in this scenario. And again, what we want to do is rapid transport, make the patient as comfortable as possible. We're not going to make the patient walk. We're going to move them either with a stair chair to the stretcher or a sheet carry to the stretcher, make them exert themselves as little as possible. And again, give the hospital a heads up what we're coming with, and patch into them and call the activation out in the field, because ultimately they're going to need definitive care and receive either fibrinolytics or a stent placement. What we're seeing here, what an MI looks like for those that aren't really sure. An MI develops what they call an ST elevation myocardial infarction. And what that really is what you're going to see is, if you look at figure 1, that's a normal heartbeat. You have a P wave, narrow QRS complex, and a T wave that's clearly defined. During a STEMI, what you're going to end up seeing is similar to figure 2 or figure 3. What's going to happen here is that T wave is going to start melding into the QRS complex. And what that's showing is a lack of oxygen being delivered to the heart muscles at that point. So what you're seeing is a lack of oxygen here. Tissue death has not occurred yet, but we are being very cautious and getting ready to get this patient to definitive care, because they need either stent placement or fibrinolytics ASAP. As the MI evolves, what's going to end up happening as it progresses even more, and this could take over the course of a couple minutes or a couple hours or even a day or so. So what's going to end up happening is you're going to see that T wave get higher and higher into the QRS complex, and then what's going to end up happening is going to be similar to figure 5 here, is that T wave is going to actually go inverted. So you're going to have a normal complex that's going to then change, where you have an inverted T wave, and you'll see that after the P wave, that Q wave is now down in the negative part of the isoelectric line. And what that is a pathological Q wave. Once that develops, that's permanent. That's an indication that there is permanent cell death or cell damage, and that person has experienced a myocardial infarction and they have permanent damage now. So if you're seeing ECG and you have a patient that doesn't have ST elevation, but you see multiple leads with a pathological Q wave, is a good indication that they have had an MI in the past. And again, we want to be extra cautious with that patient now. So again, early ischemia, what that's going to look like: hyperacute T waves at the first minute. You may see some reciprocal changes in corresponding leads. The ischemia that you're seeing here, that hyperacute T wave, is early repolarization resulting in ST segment changes. You may have elevation, and you may also have depression too. Most protocols are going to allow for ST elevation for call cath labs, and they may not call for depressions. ST elevation, ischemia, what you're seeing is now elevation in 2 contiguous leads indicate an MI. There's still tissue injury there, but damage can be reversed. So we're calling a cath lab activation if there's 2 contiguous leads of elevation. So leads 2 and 3 would be both inferior leads. If you had 2 millimeters of elevation there, you're okay to call a cath lab. Infarction, like we said, T wave inversion develops. You have the development of that pathological Q wave. Tissue death has occurred. Signs of myocardial infarction: your pathological Q wave. You have 40 milliseconds of width on it. It's going to be roughly 2 millimeters deep. It's going to be 25% of the QRS complex. It could develop over several hours or several days, depending on the type of event. Again, we need at least 1 to 2 millimeters of elevation in your ECG leads. No active bleeding, no recent surgery, and the criteria might be a little bit different based on your region. Always refer back to local protocols to see what your qualifications are to call a STEMI out in the field. But these are some of the more common elements that are needed in order to call a cath lab activation. Important to notice that if a patient has a new development of a left bundle branch block with active chest pain, we can call the alert out in the field. So in conclusion, effective cardiac management requires a thorough assessment. A 12 lead is really going to help you with identifying acute cardiac events, early recognition, early cath lab, early treatment. Remember, time is tissue. Thanks, everybody.